Hi there and welcome back. My name is John. I've been a type 1 diabetes patient for 45 years. As you know, or if you don't know, please watch some of the other videos. I've run a diabetes center in northern New York and I'm an ER physician in New Hampshire right now. These videos were started back in June to share ideas, share lessons I've learned, share some stories, have some fun, maybe educate and enhance diabetes awareness. Please don't take anything here as medical advice. Any changes you choose to make to your own therapy really need to be discussed with your provider. So last week we touched on diabetic neuropathy and we looked at the horrible things that can happen with nerve damage in the feet and numbness, tingling, pain, amputation, the whole gambit. This week we're going to talk about diabetic retinopathy. So you may not realize this, but diabetes is the leading cause of blindness in working class adults in the world. So that's huge. Okay, this is something that we can avoid and it's something that we really should struggle to avoid. Let's go over the outline here. We'll talk about what diabetic retinopathy is. We're going to talk about how it happens, touching on a little bit of physiology. I'll go a little bit deeper into damage to blood vessels because that's a critical part of all diabetes complications, especially the retinopathy. We'll talk about the statistics, how common, how frequent it is, and we'll talk about treatment, prevention, because that's what's most important in my mind. So, what is diabetic retinopathy? So I want you to think of the retina that sits in the back of your eye as a giant movie screen. Plugged into the middle of that movie screen is the optic nerve. So the movie is projected, or you look at something, onto that screen. The nerve takes that information over to the brain figures out what it is, and you create this image in your head. When that retina gets damaged, we have issues. We have all kinds of visual changes and eventually blindness. Retinal damage can occur for a lot of reasons, but today we're going to talk about due to high blood glucose levels over a prolonged period of time. Now, we touched on this last week. High blood glucose levels for a prolonged period of time can be measured with your continuous glucose monitoring system, can be measured by blood testing, and most commonly measured by the hemoglobin A1C. Keeping in mind that your hemoglobin A1C is a 3-month average. So if that 3-month average tells you that your sugars are sitting above 300 that whole time, or worse yet, you end up in the ER and they test your sugar and tell you, oh, it's 350, and you say, oh, that's normal. That's a problem. That's prolonged high glucose levels. That leads to vessel damage, retina damage, diabetic retinopathy, blindness. So that's the basic what it is. How does it happen? What's the physiology going on here? So again, think of this big movie screen. Behind the movie screen are all these little tiny wires, okay? These wires are your blood vessels, the capillaries that feed the movie screen. They feed the movie screen nutrients and oxygen. Prolonged high glucose levels damages these vessels through a number of different pathways. First is called glycation. This is essentially taking simple syrup or liquefied sugar and spraying on your clothing. So your clothing that was nice and flexible and very calm and relaxed now becomes very brittle, just like sugar would, like you caramelize the top of any dessert. It becomes very brittle and can easily be damaged, okay? The other thing that happens is the stiffening not only makes it tough for the vessel to move, but it weakens it and it makes it resistant to blood pressure changes. Then we have oxidative stress as number 2 method for damage to blood vessels from prolonged high glucose. If you remember last week, we talked about free radicals. Free radicals are angry little molecules that have an extra electron. Well, with prolonged high glucose levels, these get into cells. These get into the cells that make up the blood vessels that feed the retina, feed any part of the body for that matter. When these free radicals get in there, they cause damage to the DNA. They cause damage to the lipids, the fats that build the cell. They cause damage to the proteins that build the cell, and they lead to cell death. Well, naturally, a dead cell in the blood vessel wall is not going to allow for passage of nutrients, waste on the cellular side, and oxygen. Just not going to do its job. So that leads to cellular damage, cellular death, and all kinds of problems. Third is the endothelial membrane that sits within the cell also has another job. It releases nitric oxide. This will cause the vessel to dilate a little bit and relax, and it helps prevent clot formation, and it helps with blood pressure regulation. When these are damaged due to prolonged high glucose levels, this ability goes away. So we lose that benefit of nitric oxide in our cells of the blood vessels that are feeding everything in our body. The basement membrane of the blood vessel cells. So again, I remember, we think of, and I've done this before too, the blood vessels carrying the food to the cells. Well, they're also made up of cells. So these are the cells formed in a nice tubular formation that are important for feeding everything in the body. The basement membrane, essentially the basement of your house, becomes thickened. And it makes it much harder for molecules and chemicals and nutrients to pass in between. So that vessel wall, the vessel membrane is so thick that it can't get the oxygen over to the retina like it needs to. It can't get the glucose over or the nutrients over to the retina like it needs to. So there's another method in which prolonged high glucose levels cause damage to blood vessels, which in turn, in our today's discussion, leads to damage to the retina. There's an inflammatory component to it, with the chronic high glucose levels leading to chronic inflammation. The immune cells can form plaques within the blood vessels. So you take your big pipe and now you have a plaque on a chunk of it. So now that pipe is considerably smaller and less able to move blood. You have, talked about the free radicals, talked about the plaques, the blood flow. I think those are the major issues that occur in the blood vessels due to prolonged high glucose levels. So what happens, again, back to our movie screen, the blood vessels that are feeding that movie screen get all this damage and just don't work as well. So they start to leak. They bleed a little bit. They swell. The eye doctor might call this a cotton wool spot or a microaneurysm or a microhemorrhage. So all of this becomes a problem because where those blood vessels were plugging into the back of the movie screen, they're not providing the nutrients and the oxygen that movie screen needs. So the retina is essentially starving. As a result, the body says, oh, we'll fix this. Go to the cheapest store you can find and put up the worst product you can find to bring food and oxygen to that retina. So crappy blood vessels are made. This is called neovascularization. And they break and leak incredibly easy. Problem with these is they break and leak and they have worse bleeding. They bleed into the vitreous humor, which is the gel that sits in front of the retina, between the retina and the lens. And that can cause cloudy vision. It can cause scab formation. Scabs tend to contract as they heal, and it can pull the retinas down, or retinal detachment, which can lead to blindness. So that's the slam dunk cliff note version of what happens with diabetic retinopathy. It's a couple of different stages of diabetic retinopathy. You have the non-proliferative diabetic retinopathy stage. This is stage 1. This is where we have the microaneurysms, the cotton wool spots, the tiny little hemorrhages. We don't have any new vessels forming yet. That's stage 1. Stage 2 occurs when the neovascularization or new blood vessels are being formed. And remember, these blood vessels are weak and brittle. They stink at what they're doing. They bleed very easily. They lead to clot formation. They lead to scab formation. They lead to retinal detachment and blindness. So I guess if you had to pick one, you want stage 1. Ideally, avoid them all and let's not get any of them. Some of the symptoms you might see, well, most of this is pretty quiet, okay? Very few people come in and immediately say, oh, I'm having eye trouble, and they say, oh, well, this is a little tiny microhemorrhage at 3 o'clock in the retina. Yeah, it doesn't happen like that because that part of it is silent. It's not until things progress you start to get a few floaters, little black spots floating around your eyes. Or you may notice a complete blurred vision as that vitreous humor, that gel fluid, gets bloody. If scabs form, you'll see the retina starts to pull, and people often describe this as the curtain is closing as they lose their sight. So those are the main symptoms. What I think is most important to remember, the early stages, the beginning, is silent, and that's the time we want to pay very close attention to and make sure nothing happens beyond that. So how do we do this? Well, actually, before we do that, let's talk a little bit about the stats of it. Some scary stuff here, especially for me at 45 plus years and 50 years old. 1 in 3 patients with diabetes over the age of 40 will have some stage of retinopathy. 1 in 3, so 33%. And keep in mind, this isn't just a type 1 disease. This is type 1 and type 2. So 1 in 3 over the age of 40 will have some stage of diabetic retinopathy. Okay, it's a major cause of blindness. We talked about it's the #1 cause of blindness for working age people in the world. These numbers are extremely closely linked to another scary fact, the duration of diabetes. So the longer you go with it, obviously the more opportunity for prolonged high glucose levels, and therefore the more opportunity for this complication. It's also very closely linked, not surprisingly, to glucose control. So that's the nuts and bolts of it. How do we prevent it? #1 most important method to prevent diabetic retinopathy and the various issues that follow is regular ophthalmology visits. These should be at least annual, and if there is a need, your ophthalmologist will tell you, I need to see you next month, I need to see you in 3 months, 6 months, what have you. At the very least, it will be annual. If you're at 45 plus years with diabetes and you still only have to go once a year, good for you. Keep up the good work. Help others do the same. So I always use this as a measurement of how am I doing. There was one period of time where I had to come back in 6 months, and I think I was depressed and heartbroken. But it's important, no matter whether it's every 6 months or every year, that you do these visits, because this is how we prevent major things from happening. How do they treat it? Okay, let's say they find you in stage 1, non-proliferative diabetic retinopathy. What are they going to do to help you? So a couple things can be done. You've heard about laser eye surgery. This is done for cataracts frequently. It can also be done specifically to treat these microhemorrhages and little aneurysm. It will seal off the blood vessel, essentially cauterizing the blood vessel. Instead of using heat like we use in the operating room or in the ER, they're just using the laser to burn it. Injections can be given. There's 5 or 6 different medications they can inject. I'm not going to try to pronounce them. I never use them, so I apologize. But they do have injections that prevent the new blood vessels from forming. So, okay, you have stage 1 or non-proliferative diabetic retinopathy. You go into your eye doctor, says, hey, you know what, there's some few microhemorrhages in there I'm a little concerned about. Let's set you up, get those treated. So you go back in a week, they do laser on your eyes, and they burn those off. You're stopped at stage 1. Now it's up to you to prevent any progression or any worsening. Stage 2, they say, okay, you know, there's some new vessels starting to form and getting leaky. I don't want this to cause you to have blurriness as it leaks into the gel fluid, the gel substance there, the vitreous humor. So come on in for an injection. So they'll do a series of injections to help prevent the development of these new vessels, to help stop you. Even though you're now in the proliferative diabetic retinopathy stage, they're going to try to stop the progression beyond that. The other treatment option they often use is a vitrectomy, where they go into that vitreous humor and get rid of the blood, clean it up, get rid of any scar tissue to help prevent that retina from being pulled, or the curtain from being closed, to prevent the blindness. So the moral of the story is there's a lot of treatments available for the various stages of diabetic retinopathy to prevent the outcome of blindness. Most importantly is the preventative visits to your ophthalmologist to catch things very early. And even before that, incredibly importantly on all levels of diabetes, is tight glucose control. Monitor your blood pressure, monitor your cholesterol, stay active, but keep those blood sugars under control. If you're not using a continuous glucose monitoring system, otherwise known as a sensor, please look into it. It makes your life incredibly easy. It's very educational and extremely helpful, even for your providers. They can download that data. Monitor your A1C every 3 months. This is counting glucose particles on a red blood cell. Red blood cell lives for 3 months. That's why we repeat the A1C every 3 months. And that provides an average blood glucose level for 3 months. I'm not a big fan of it because, as you know, you can affect your average with really, really highs and really, really lows. That spread and that constant fluctuation creates more free radicals. When we don't have enough antioxidants to handle those free radicals, like we talked about last week, we get all kinds of problems. But we get blood vessel damage because of what the free radicals do in the blood vessels. So regular checkups with your provider, regular A1Cs, consider the sensor if you haven't already. If not, frequent blood glucose testing is essential. But most importantly, get to that eye doctor at least once a year to get a dilated eye exam and see what's going on. I'll give you let's just do a Cliff Note quick review of everything. Diabetic retinopathy, #1 cause of blindness in adults and working age in the world. It's It's a preventable complication of diabetes. It's secondary to prolonged blood glucose levels over a period of time that damages the blood vessel walls. We went through all the methods that the blood vessels get damaged. I shouldn't say walls. Walls is a bad term in a mammal. It damages the blood vessels. Therefore, when they're damaged, they cannot provide the nutrients and the oxygen that the retina needs. New blood vessels form, and these are even worse. They break and bleed very easily. We get scarring, we get retinal detachment, we get cloudy vision, we get blurry vision, we get blindness. We prevent this with annual ophthalmology appointments. And I say ophthalmology because this is incredibly important. You have a medical diagnosis which enables you to go to the ophthalmologist. The ophthalmologist is the physician, okay, MD or DO, that specializes in eyes, is also a surgeon. With diabetes as a diagnosis, don't let them tell you your ophthalmologist doesn't take your insurance. That's simply because the receptionists don't understand that you have a medical diagnosis to go with it. Let them know that you're there for diabetes, be it type 1 or type 2. You need that ophthalmology evaluation. God bless the optometrists. They're wonderful folks and they're very good at what they do. But I really encourage folks to start with the ophthalmologist, stick with the ophthalmologist for your regular annual checkups. If you need to go more, you go more. If you need treatments, there's lasers, there's injections, and there's surgeries that can be done to help prevent a nasty outcome. So please like, comment, subscribe, give us your ideas, your thoughts. If you have a nasty story about diabetic retinopathy, I'd love to hear it. I pray you don't. If there's any way that I can help you, please send me your questions. If you have ideas for another video, let us know. If you enjoy these videos and want to see more of them, please subscribe if you haven't already. And most importantly, like you always hear from me, go to the ophthalmologist every year and be healthy.